Today's lecture is on decision and compliance support, utilizing the database. Using the dashboard in Prime Suite to meet meaningful use standards. Meaningful use of electronic health data. Statistical report that includes totals for all patients. It's called aggregate data, rather than for an individual patient. It is required by high-tech legislation in order to receive stimulus money. Eligible professionals and hospitals that implement certified EHR systems are eligible for monetary grants and avoid non-compliance penalties, which are monetary. Must demonstrate compliance with core and menu objectives. Meaningful use was developed to ensure that the use of EHR systems by healthcare providers will improve quality, safety, and efficiency and reduce health disparities within healthcare. Meaningful use health outcomes and policy priorities include improving quality, safety, and efficiency and reducing health disparities, engaging patients and families in their own health, improving the coordination of care, improving population and public health, and ensuring adequate privacy and security protection for personal health information. You should know these meaningful use health outcomes and policy procedures to the T. Memorize these, write them down, know them, be able to spit them out when you're asked. This is very important information for y'all. The Centers for Medicare and Medicaid Services, known as CMS, administers the Meaningful Use Program, the MU. It has developed a plan for implementation of 3 stages of MU within 5 years, and this has already occurred. Stage 1 is focused on data capturing and sharing and was implemented in 2011 with 15 core objectives. Stage 2 was currently in progress, and there are 17 eligible provider core objectives. Stage 3 focuses on demonstrating improved outcomes being finalized for implementation by 2018. So meaningful use is now permanent and in place. Core objectives are basic functions that should be completed on a patient's visit. Menu objectives are additional functions that allow for greater use of EHR functionality. So you have the mandatory and then the addition. Medicare Core Objectives, 2011, Stage 1. Use of computerized physician order entry, electronic medication orders. Drug and drug allergy checks. Alert system to identify allergies or drug interactions. E-prescribing. Prescriptions are placed electronically. Recording of patient demographics must be collected on all records. Preferred language, gender, race and ethnicity, and date of birth. And these are Medicare Core Objectives. Recording of a problem list. Maintenance of a list of current and active diagnoses. Recording of a medication list of all current and active medications being taken by the patient. Recording of a medication allergy list, a list of medications to which the patient is allergic to. And recording of vital signs. TPR, BP, height, weight, and body mass index. BP is blood pressure. Maintenance of growth chart for children 2 to 20 years, including BMI. Recording of smoking status. Patients 13 years or older must have recorded smoking status. Clinical decision support and functionality. At least one clinical decision support rule must be implemented with each visit. Reporting clinical quality measures. Each provider must specify reporting numerators, denominators, and exclusions for each quality measure recorded. Information exchange between and among care providers. Capability to share among providers such information as the problem list, the medication list, allergies, and diagnostic test results. The ability to provide an electronic copy of health information. Patients must be provided with electronic health information upon request. Remember how I said my office said, would you like this printed or sent to your portal? The ability to provide clinical summaries. It should be provided to each patient as well. Privacy and security provisions. The EHR software meets or exceeds ONC meaningful use standards and includes technical specifications to ensure privacy and confidentiality, such as encryption and password use, and how often are the passwords changed. Hospital must meet all core objectives except e-prescribing. Now, Medicare menu objectives 2011 stage 1. 5 menu objectives must be met, one of which must include a population or public health measure. So drug formulary checks. This is access to at least one internal or external drug formulary, which is a list of provider-preferred generic and brand name drugs covered under various insurance plans. Number 2, lab test results documented in the EHR. Results of lab tests must be entered into the EHR rather than filing in paper format. Number 3, keeping of patient lists. The ability to generate a list of patients with a specific condition for quality improvement research or patient outreach. Number 4, patient reminders are generated. Ability to send letters or electronic reminders for preventive and follow-up care. Number 5, timely electronic access. Ability to provide patients with their electronic record within 4 days of becoming available. That's the patient portal. Patient education, number 6. Access to educational resources using EHR technology. And lastly, medication reconciliation. Documentation of medications the patient is taking. Summary of care. Care provider submits a summary of care to other providers that will be assessing or taking over the care of the patient. Immunization registries. Capability to submit electronic data to immunization registries. These are public health initiatives. Syndromatic surveillance. Capability to submit electronic data to public health agencies in accordance with applicable law. Menu objectives are additional functions that allow for greater EHR functionality, such as statistical reports, registries, lists, checking for drug interactions, providing patients with educational materials, and so on. Eligible professional core objectives, stage 2 of meaningful use. Implementation of stage 2 requirements was extended through 2016. And there are 17 EP core objectives to meet stage 2 meaningful use. All 17 are required. Stage 2 requirements encompass the stage 1 requirements with stricter guidelines and more detailed explanations. EP menu objective stage 2, meaningful use. EPs are required, eligible professionals are required to comply with 3 of the 6 menu objectives to qualify for meaningful use. Stage 2 requirements provide additional menu objectives. Example of EP core objectives, comparisons between stage 1 and 2. Stage 2 explanation. Incorporate clinical lab tests resulted in certified EHR technology as structured data. For stage 1, they required more than 40% of all clinical lab test results ordered by the EP during the EHR reporting period whose results were either in a positive, negative, or numeric format be included in the EHR as structured data. Stage 2 required more than 55%. Hospital core objectives. Similar to core objectives listed for eligible professionals. Inclusions. Demographic objectives include date and preliminary cause of death in the event of mortality. Required to submit electronic syndromatic surveillance data to public health agencies and must have the electronic means to track medications with electronic medication administration records. Exclusions. Requirement to generate and transmit permissible prescriptions electronically is a menu objective, not a core objective. Requirement to receive reminders for preventive follow-up care does not apply. Hospital menu objectives, stage 2, must meet 3 of 6 possible objectives. Record whether a patient 65 years or older has an advance directive. Record electronic notes in patient records. Imaging results, the images themselves, and any explanations as accessible through CEHRT. Record patient family health history as structured data. Generate and transmit permissible discharge prescriptions electronically. And provide structured electronic lab results to ambulatory providers and transmit permissible discharge prescriptions electronically. Structured data is preferable to unstructured data. There's more continuity, and data elements must be chosen from libraries within the EHR system rather than being written in free text within EHR notes. More functionality was added and measure thresholds were increased for meaningful use stage 2. Emphasis on the ability to share information with other providers and healthcare facilities, which improves patient outcomes. Dashboards. Meaningful use dashboards are important components of EHR programs, and it allows comparison of actual performance to required performance. Data and information used in decision support. Clinical Decision Support, CDS. We talked about that a couple of lectures back. According to HIMSS, CDS is defined broadly as a clinical system, application, or process that helps health professionals make clinical decisions to enhance patient care. CDS includes reminders and alerts, diagnostic and therapeutic guidance, links to expert resources such as the CDC and clinical trials, results of best practices. Many EHR vendors link to CDC sites. Data captured in EHR triggers clinical alerts and support and uses the data dictionary and structured data. Benefits of use of CDS tools: improves patient safety, decreases duplication of procedures, reduces the performance of unnecessary testing, results in decreased cost of healthcare. It improves patient outcomes, efficiency of care, and provision of clinically relevant evidence-based care. It's built into most EHRs. It assists in improving patient compliance and assists providers in providing quality care. We've heard this before. We will hear it again and again and again through meaningful use measures, that these clinical decision tools, again, are the basis for the electronic health record. Why do we use an electronic health record? To improve patient safety, to decrease duplication of procedures, and so on. Meaningful use in CDS. Meaningful use requirements. At least 5 CDS interventions related to 4 or more clinically quality measures are in place, and it must be implemented during the entire reporting period. Chart audits. Our parameters can be set for specific objectives and wellness initiatives. EHR systems have the ability to audit patients' charts. It identifies if they are overdue for a screening or testing. It ensures providers can order tests and screenings when they are needed. It allows patients to remain proactive in their own healthcare, and it can lead to earlier detection of disease. Pretty cool, huh? Use of report writer for system reports. Reporting abilities. PM and EHR software systems have the ability to run standard reports. And examples of reports include, but are not limited to, payment analysis, procedure code analysis, provider revenue summary, patient balances, referring provider, appointment analysis report. Reports are necessary for efficient management of any practice. Reports assist in decision-making processes, identification of trends and future forecasting. Summary reports, excuse me, include statistical reports, include totals rather than data for individual patients, or aggregates, the sum total, excuse me. Detail reports, any report that includes patient identifying information and lists cases individually rather than as a total number of cases. Custom report writing is designed by the office or hospital rather than coming as part of a software package. We have standard reports, then you have custom reports. And they can be built to include variables, factors that vary from one patient to the next. They're needed to answer queries from various entities. Benchmarking. Comparison of one set of statistics to the overall statistics available, and comparisons use the same variables. While reports can be run to provide generic information, care should be taken that no patient information is shared publicly. Uses of indices. Listings, they're used to find basic information. Example, a master patient list or patient index is a listing of all patients in a health system. And it includes basic identifying information. In-network, care providers who contract with a managed care plan. offers services to members of the plan at a pre-negotiated rate. Managed care plans often seek information about the type of patients treated by a practice by referring to the physician's index or disease index, and this information determines consideration for in-network status. How about use of registries? Registries are listings in chronological order, and examples include, but again are not limited to, admission and discharge registries, which list patients by date, birth registries, which are kept by the date and time of birth, death registries, which are kept by the date and time of death. Cancer registries are required by law. Registries for all patients diagnosed and treated for cancer and are used for data collection, research, and reporting to the Centers for Disease Control and Prevention, known as the CDC. We have trauma registries. All patients diagnosed or treated with traumatic injuries are reported to the trauma registry. Examples include, but are not limited to, as we continue, immunization registries. This is important to public health, and some states require reporting of immunizations by law. Massachusetts does. Birth defect registries, HIV/AIDS registries. Now, Physician Quality Reporting Initiative measures the voluntary pay-for-performance incentive program. Participating providers submit data on any of the 100 designated quality measures, and information received from registries satisfies PQRI, Physician Quality Reporting Initiative measures. I think we just skipped a slide. Hang on. We did. National Practitioner Data Bank, the NPDB. A database including malpractice payouts, revocation of privileges, licensure denial or suspension, or denial of medical staff privileges. Reporting adverse actions to the NPDB is required by law, and the databank should be queried prior to hiring and issuing privileges. The Healthcare Integrity and Protection Data Bank is a database of adverse actions related to fraud and abuse, and reporting for HIPDB and NPDB can be done on one site. The credentialing process. What is credentialing? It's a process of ensuring a care provider has the proper qualifications to practice medicine, education, experience, malpractice coverage, and identifying information. Its information is maintained for reporting purposes when healthcare professionals apply for board certification, file for renewal of their medical licenses, apply for hospital privileges, or report to managed care entities. These are not medical assistants, ladies and gentlemen. These are licensed practitioners, physicians, nurse practitioners, nurses, and physician assistants. And that ends our lecture today on decision and compliance support utilizing the database.